Okay, and we are live. Here we go. All right, I just want to welcome everybody for attending today's webinar. It is really exciting stuff. Um, we have Vanessa Costa, who has been willing to come and present her wonderful topic. And let me make sure I have the right title right here. Okay. It is from the drawing board to lived experience and back, co-producing co-producing language justice infrastructure to advance health equity. And just really, really great stuff there. Um, she is, oh, I lost my bio here, guys. I'm so sorry. I just had some Windows quit on me here. So forgive me 1 second. Okay. So Vanessa Costa is the Senior Director of Quality and Member Engagement for the Healthcare Interpreter Network, also known as HCIN. Really great stuff. They're a collaborative of healthcare systems that share interpreting resources. Prior to her position, she was also the Director of Multicultural Affairs and Patient Services at Cambridge Health Alliance. And that was named the #1 hospital in Massachusetts for health equity and community benefit by the Loan Institute. That's really awesome stuff there. Needless to say, she's also been involved in many things. She's also working with CCHI as well as a commissioner. And she is also, I believe we refer to it as chair. If I'm wrong, Vanessa, you can correct me once we get you back on stage. So she's also the chair of our for CCHI. And I have the wonderful opportunity to work with her and others on advancing CCHI's mission and helping raise standards for healthcare interpreters and making sure our patients have wonderful access. Needless to say, Vanessa is extremely qualified to speak about this topic. So now I'm going to go ahead and invite her up so that she can present the From Drawing the Board to Lived Experience and Back, co-producing language justice infrastructure to advance health equity. Vanessa Costa.
Thank you, Sean, and hello, interpreters. It is such a pleasure to be with you today. And I love getting groups of like-minded people together to have conversations about topics as rich as building language access infrastructure. This is something that we're all interested in as linguists, as interpreters, as healthcare administrators, as language justice advocates. And it's wonderful to dedicate some time to think about how we are building, what we are building, and to what extent we're involving the end users in the design, in the implementation of language access programs. So, when we're talking about hospital language access in the United States, it's important to understand a bit of the landscape. What do we know about the state of language access in US hospitals? Well, we know that the number of patients receiving care in languages other than English has increased significantly over the past decade. We also know that as recently as 2016, in a self reported study conducted by the American Hospital Association, nearly one third of US hospitals reported that they don't have a language access program. Nearly one third of US hospitals fail to offer language services. And for those of us who work and live in local communities, we know that even hospitals that have language access systems in place, there's a lot that happens that deviates from what should be happening or from our goal. Over half of medical communication everywhere occurs without professional interpretation. And that's a staggering statistic to think about. We also know that in many parts of the country, hospitals are downsizing in house interpreter teams and outsourcing language access. And interpretation in local institutions is no longer being done by local interpreters who live and work in the same communities. Coming back to that 2016 article in Health Affairs, in a survey of 4,500 general hospitals, the majority of private not for profit hospitals offered language services, but it ranged from 62% to 70%. More than 18% of private for-profit hospitals um, did not offer, I'm sorry, no more than 18% of private for-profit hospitals offered language services at any need level. And government hospitals offered services at a rate that was similar to the for-profit hospitals. So, 2016 is 8 years ago. And in between, we've had 4 years of a pandemic. This study has not been repeated. We don't have a more recent data set this large, but we know that going into the pandemic, hospitals that didn't have robust language services struggled to create them or to build something new during that time of very, very thin resources. And so we can extrapolate that likely the numbers are similar today, and that there's still a lot of work that needs to be done in our local communities to build up the language justice infrastructure. So that's the state of the state on US hospitals. What about clinics? Uh, we have a little more recent data. In November 2020, there was a survey of 273,000 ambulatory clinicians. And the survey asked them questions about, how often do you utilize a bilingual staff member or a patient's friend or family to interpret? And they reported that, yeah, we frequently do that. In the survey, nearly 40% of the respondents said they had never worked with professional interpreters, ever, as ambulatory clinicians. About 50% said, yeah, we have some translated materials available, some of our vital documents. About 25% of the clinicians said, yeah, we have advanced directives in some other languages. But a third of the clinicians said, no, we don't provide written translations in our clinic. So we know that there's a lot of work to do to shore up the language access infrastructure in clinics as well. Now, we don't want anyone to get too depressed about this. Of course, it's a challenge to build something better and to strengthen the systems that are already in place, but it's also a tremendous opportunity. The president of IHI said that there can be no progress on healthcare quality without progress on health equity. So we know that it's worthwhile to focus on building better systems for health equity because that's where we're really going to make progress on quality. But an even more impactful quote is from Andrea Escalera. She's a worker at the Center for Health Progress, an immigrant, a heritage speaker. And she wrote, "There is no health justice without language justice." And in this commentary, she said, our healthcare system continues to prioritize profits over people, and healthcare executives are patting their own pockets at the expense of non English speaking communities. And she concluded by saying, we, the non English speaking communities, need to be the ones determining what meaningful access looks like. And what Andrea's talking about in different terms is really the concept of co production that we're going to consider today. The Journal of Ethics, which is published by the American Medical Association, in November 2017, in an article about co production, they wrote co production of health services can be used as a means to rethink how healthcare is delivered, not only in the context of face to face encounters, in which the benefits of working together are obvious, but also in designing systems that can improve patient care and enhance value. And there's a link here to that article, which is really, really worth reading. Now, co production is not something that we talk about often in the language access world, but it is something that's being talked about now in the world of healthcare quality improvement in general. And a lot of the principles of co production do apply to how we build language access programs. But taking a step back in history, um, as far back as Hippocrates, clinicians have been thinking about patient relationships. Hippocrates wrote, "The physician must not only be prepared to do what is right, but also make the patient cooperate." Now, that sounds a bit dogmatic, make the patient cooperate, but what he was saying is that without the patient's contribution, we cannot achieve our goals as clinicians or as healthcare systems. Now, the Institute of Medicine in modern times has named patient centered care as one of the six principal domains of healthcare quality. And we have many, many studies. We have a body of evidence that shows that informed, engaged patients really do contribute or facilitate good health outcomes at lower cost. And because of that, today we're seeing that more payers of healthcare services in the US health system are seeking the healthcare consumer evaluation of the patient experience. So they want to know how patients evaluate their own patient experience, and they're tying that now to reimbursement. They're looking at patients' self reported experience as a measure and as a measure that is factored into the formula of pay for value, not just pay for service. So, quite an evolution from Hippocrates thinking, we need to make patients cooperate. But very interesting that since the beginning of healthcare, it has been evident that without patient participation, we cannot achieve our goals. Now, the fundamentals of co-production have been, written about by Dr. Marin Batalden and her father, Dr. Paul Batalden. They have really pioneered the idea of co-production of healthcare services. And the quotes that you see on screen in the next few slides actually come from an article that they wrote that was published in the British Medical Journal of Quality and Safety in 2016. And they said we have to stop thinking of healthcare as a service. Sorry, as a product that is for sale or that we provide. We have to stop thinking of it as something that is prepackaged. We need to think of it rather as a service. And the difference between a product and a service is that products are manufactured for the use of a consumer, whereas services are always co-produced by the professionals providing the service and by the consumers of the service. And you can think of service as experience. When we think of patients as consumers, we're not thinking in terms of capitalism. The word consume in Latin has two different roots. One of them is more negative, which is to destroy or to use up something. The other is much more positive. The consumer completes or perfects something. They are consummators who create value. And so when we think of patients as consummators, those who complete or perfect the service, then we begin to see that, involving them in the research around the healthcare system, involving them in the design, in the production, in the delivery, and the evaluation is essential because that will help us to complete or perfect the service that we are offering. So it's a paradigm shift. It's a different philosophy, a different way of thinking about what's offered in healthcare. Not a product that comes prepackaged, but a service that is co-produced with the consumer and the provider. Now, other clinicians have written about this as well. Coming back to the American Medical Association Journal of Ethics, Pooja Turakia and Brandon Combs, they wrote an article about, how we need to stop thinking about patients as users and choosers and begin to view them as makers and shapers. If we look to patients as makers and shapers, then that allows for planning new and better policies and processes that can lead to better health outcomes and better patient experiences. So, co production in a nutshell means that we are involving the patient, we are co planning, co prioritizing, co designing, co delivering, and co assessing the service that has been co produced. So it's interesting to think of this at the higher level. We're also wanting to think of it as, how do we do this? What's the practical application? But before we get to how we do this specific to building better language access systems, we can take a page from the UK. Uh, there is an article about co-production of health and well-being in Scotland, and this is not about language access; it's about health system in general. And they're looking at, a socialized health system, but they're looking at a project that involved the community or the end users in the design of what was being offered. And they said, we know that there are benefits of co production in all public services. When we involve the end user or the community, we are employing their expertise. We're enabling more differentiated services and more choice. We are responding to needs in real time as they're changing. We've got a finger on the pulse of what the community is looking for, and we have this opportunity to reduce waste and cost. So really, it's a win-win all around. Articles like these should lead us to think about, how have we built our health systems? In particular, how have we built our language access systems in healthcare? And how can we make them better through applying the principles of co-production? So the Robert Wood Johnson Foundation has been looking at the lived experiences of community members. And they have coined the term PWLE, people with lived experience, and have set these aside as subject matter experts in the design of health systems in general. And this idea of experience-based co-design as a framework is being promoted now. Let's invite the focused attention of people with lived experiences wherever we can find them. And maybe they are our patients, maybe they are family members of patients, maybe they are healthcare professionals, ideally professionals who live and work in the community and who may also be patients themselves. And how do we bring them together to do collaborative work in system redesign? And so there's a lot of focus on this now. Where do we find the people with lived experiences and how do we bring them to the table very early on in our healthcare system redesign? The Robert Wood Johnson Foundation and the Institute for Healthcare Improvement actually launched an initiative, and it ran from 2014 to 2020. It was called the 100 Million Healthier Lives Initiative. And the object was to transform how we think about health, well being, and equity. And the initiative came up with several toolkits. One is called the Community of Solutions Framework. One is a resource or clearinghouse called 100 Million Healthier Lives Change Library. And then the third is a toolkit called Engaging People with Lived Experience. And you can find all of these resources on the ihi.org website. Um, the toolkits were created or co-produced with healthcare workers and consumers of health services, and they have been applied in many different scenarios to build or improve on many different aspects of our healthcare system. It is possible to use these toolkits in building better language access systems. And later on, I'll give you examples of hospitals that are doing that in specific areas of access. So, what is a person with lived experience? This is a person who has expertise that comes from life, not necessarily from formal education in the area being considered. These are people with direct experience with the system or with the process or with the issue. We're trying to engage them as a resource. These are people who know from experience what has worked for them, what doesn't work, and what resources might already be available in their community. When we're thinking about, redesigning a program, and we're thinking about finding people with lived experience, we need to ask some essential questions, and these are outlined in the Getting Started with Engaging People section of the toolkit. Some of the recommended questions are, who is most affected by this issue? Find those people and bring them into the room. What voices have not been heard? In every community, there are louder voices and softer voices, and even voices that haven't yet been heard. And it may be that we consistently hear the louder voices more because they're louder, because they're more present, because they're engaging more with our systems. And yet, the experience of the louder voices may not be representative of the experience of the softer voices in the community. So it's important to think about which voices are we hearing? We need to have them at the table. And which voices or perspectives have not been heard yet? Let's go and find them in the community and also bring them to the table. And then it's also important to ask, the people with lived experience, what do they already have? What do they need to participate in this project? And what are they possibly ready to grow into? And we want to make sure that the work aligns with their interests and aligns with their resources because these improvement projects, the work of building better language access infrastructure, this is not something that happens in a day or in the course of a couple of meetings. This is work that takes weeks, months, years, and we want to make sure that we have people who are committed for the duration or the scope of the project, and that we're providing them with the resources they need to continue active and not drop out. So, getting started requires some advanced planning, even when it comes to identifying which people with lived experiences are we going to invite to participate in this redesign. Now, in terms of connecting with people with lived experiences, once we've figured out who we want, we need to go out and find them. We need to meet them in the space of their choosing, and that helps to build their trust. We need to show them that we respect their time and effort, and that participating with us in system redesign will bring value. Sometimes it's helpful to connect one to one. Sometimes it's helpful to go out and find small groups. It's often important to consider what is fair compensation if we're inviting, as a healthcare system or a government system, as an organization, if we're inviting individuals and groups to participate in the work of redesign, we need to figure out what is fair compensation for their time and knowledge, because the representatives of our hospital, our organization, our government office are being compensated for their time. People with lived experience also do need to be compensated for their time on the project. Now, when we're introducing ourselves, especially if we're not already tapped in to this group or this community subset, we need to be clear about who we represent. Introducing our organization, we need to be clear about, the purpose of approaching you is to invite you to collaborate and to co-design solutions together. And we need to spend some time getting to know each other so that we ascertain that we found the right people and they ascertain that they found the right organization, an organization worthy of their time and their efforts. Now, the IHI, on their communitycommons.org website, they have a section called Connecting and Engaging People with Lived Experience. And they say that, initially when we have these conversations, we're thinking about inviting individuals and groups to participate in a project for improvement. We need to ask them what their concerns are about the thing that we're trying to redesign or improve, what their priorities are. It's important to ask them what challenges and barriers they have experienced, what resources already exist that we might not know about as representatives of an organization. Those resources might be outside our organization or they might even be inside. What strategies are the people with lived experience aware of that have been tried before by our own organization or by others? A really crucial question that can sometimes be difficult to ask and even harder to hear the answer to is, where have people made mistakes in the past that might have caused harm? And it can be painful to hear from community members where our organization has made mistakes that might have caused them harm. And yet it's important to listen, and to actively listen, because we don't want to repeat those mistakes. And we also want to validate the experience of folks who feel that they have been harmed by prior initiatives, even from within our organization. We might ask, who else should we talk to? And they might be able to suggest other collaborators. And we might also want to ask a little bit about background. What else should we know about this issue that we're trying to improve? And when you have these conversations specific to language access, sometimes community members will tell you, 5 years ago, your organization launched this new product, or they, contracted a new vendor, or they made a major change in the language access program, and the community received it well, or it didn't, or mistakes were made and harm was done. And so those experiences that the people with lived experience have had, may have shaped how they view your organization and whether they view it as an organization worthy of continuing to collaborate with. So, difficult conversations, perhaps, really essential conversations, and conversations that need to happen at the beginning, even as we're inviting people to come to the table for a project design. Now, in terms of getting to and staying at the drawing board, when we're preparing people with lived experience for project engagement, it's important to lay out what are the expectations, what are the hopes of the organization, as well as the hopes of the participants. We need to, again, provide them with support, and that might not be just compensation for their time, but they might also need things like flexible meeting times, transportation, childcare. All of these things might be factors in whether they can participate, for the duration of the project. I remember in an organization up in Massachusetts, there was a real interest in involving deaf and limited English proficient immigrant populations in the Patient and Family Advisory Council. And invitations were extended, relationships were established, and yet after one or two meetings, the representatives tended to drop out, and they would say, "I'm not able to attend." And a lot of it had to do with the timing of the meetings. If you hold your meetings during the workday, well, that's also probably the workday of your person with lived experience. Can they take time off work? Or not. And most of the folks that we're inviting to the projects don't have, complete control over their time in that sense. And so meetings were changed to happen in the evening. And that was not convenient for folks who worked within the organization. And it did require an investment in overtime to compensate the organizational representatives who would be in that group, but it did make it possible for people with lived experience to participate more fully, more consistently, and for the duration of the project. So very interesting in thinking about, what do PWLE need to engage with us in this way. And it's important to model the co-design even in establishing the parameters for collaboration and asking them, what do you need? How else can we support you? How can we collaboratively solve whatever barrier it is that prevents you from getting to the table? Yeah. Now, when you're convening a group of employees and community members, it's important to give everyone, the scope and the goals of the project, background on past work or work that might be in progress, um, an introduction to quality improvement methods that might be more familiar to the folks working inside the healthcare organization than to the people with lived experience coming in for collaboration. It's important that everyone have easy access to the minutes, to the materials, to the products that are being produced in these collaborations, and clarity on what the different roles are. So, an interesting point, people with lived experience are initially invited to the table because of their lived experience. But it's important that they not feel that that's all they can offer. Some folks come with a story, and it's a story that they tell and that they feel comfortable telling publicly, and maybe that story brought them to the table. But if they feel obliged to tell it at every meeting, they're not going to grow personally or professionally, and the project may not advance. So it's important that they're made to feel that they are also a teammate, even if not employed by the organization, not just the voice of their experience. And it's important that institutions look at these people with lived experience as, you know, to see their potential and how can we help this person to take on perhaps a broader role within our organization, a broader role within the community. How can we offer them skill building opportunities so that when the project is done, they come away with more skills, with a bigger personal toolkit as well. So, it's possible that the team may need to adapt, develop new behaviors, facilitate in different ways. We talked earlier about the louder voices and the softer voices. We need to have designated facilitators at these performance improvement meetings who are going to make sure that all perspectives are voiced, and they'll facilitate the meeting in a way that avoids groupthink, and that encourages that range of perspectives. It can be hard as a facilitator to balance the people who are quick to respond and those who might need a moment, to balance participation from the employees of the organization and from the people with lived experience who are coming in for the project. One helpful tool is to end all of the meetings with what's called a plus delta discussion, where each person contributes something they think went well and something they think could be improved for the future meetings of that group. And that allows the whole team to adapt to what they hear from each other and not just from the facilitator. All of these are best practices that are outlined in the IHI toolkit. There's a lot more information there if you are looking to adapt them and to implement them in your work within your institution. So, in terms of the co-design, there are steps. The very first step in quality or process improvement might be to map the experience of the end users, the patient experience, as well as the provider experience. And you might need to create a patient journey map. I'll show you an example in the next slide. This is a really common tool in the hospital quality improvement world. Once we've mapped out the journey, it helps us to see, where the pain points are and where the positives are. And then looking at the pain points, we can agree as a group on what should be our priorities because an improvement process is usually more effective if it has a narrow scope as opposed to trying to change everything in one project. Once we've agreed on shared priorities, we can co design a potential solution, plan small tests of change, determine how we're going to measure whether something works or doesn't, and then test out those changes. Really important to look for metrics that examine the process from both perspectives, the people carrying out the work and the consumer experiencing it, and to ascertain whether something is working for everyone involved. And then sometimes in process improvement, after those tests of change and the analysis of the metrics, we get together and decide, is this something that we need to adapt? Is this something that we're ready to adopt? Or should we abandon this idea and start from scratch? Or go back to the process map and redesign another potential solution? And that experience also can be painful because there's an emotional investment in things that we've worked on, but not everything we work on is successful. So, very interested in looking at the process of co design in quality improvement. This is the sample of the patient experience map that I mentioned. This comes from the ahrq.gov site, and it's actually a Veterans Affairs patient map. And it's a little blurry here. If you go to their website, you'll be able to see it more clearly. But it maps out all of the steps in the process of a veteran who is trying to receive care. And it maps out, you can see the sections, the steps they have to go through before the visit, the steps they have to go through in arriving to the facility, the steps they're going through during the appointment, the steps they have to go through after they leave, and then the steps they go through before their next visit. And it's quite involved. And then you can see there's a plus and a minus. What are the bright spots from the veteran perspective? What are the pain points? And then there are quotes from the participants in the project about why these are bright spots or pain points. And mapping it out like this helps us to see gaps. It helps us to see system breakdowns. It also helps us to prioritize which pain points are more painful and focus our group attention there. So the experience map is an actual visualization of an end-to-end experience that a generic person would go through to achieve a goal. And in this case, when we're talking about how patients with, you know, who require care in languages other than English experience our systems, their map is going to look different, perhaps, than the map of an English speaking patient or a hearing patient. And that's okay, but we want to make sure that these experiences are as equitable as possible. And so it might be necessary in our improvement to map them both. What is the experience of an English speaking hearing person? What is the experience of a deaf person who uses American Sign Language? What is the experience of a Vietnamese speaker who is limited English proficient? And if they are radically different, that also might show us where the inequities lie and give us ideas on how we can streamline. Not that the same solutions work for every group, but we want to make sure that the solutions that we're co-designing do have an equitable result, that they do contribute to health equity in each population. and that no population is overly burdened by the steps that we make them go through in comparison to any other population. So very interesting to try to map out the experience. Now, when we talked about small tests of change, you might be familiar with PDSA, Plan, Do, Study, Act. And this is how change is implemented in healthcare in the US and also in other fields as well. These small tests of change help us to see if our solutions are viable. And if the small tests of change are successful, then we can broaden and apply those solutions more widely. So we start small scale, we measure and perfect, we test under new conditions, and eventually we ramp up to a wider scale. And it's important that our everyone at that design table, that drawing board, is talking about, okay, why does it matter to test this particular change? Um, what will make this process or experience better? How will we know that we made it better? By when should we see improvement? Setting some timeline around it. And then, if we can't prove that we made it better, then it's back to the drawing board to experiment and adjust and refine and maybe test something different or test this under different conditions. I know these are abstract concepts, but they are the fundamental quality improvement principles. And each one of us can think about, okay, how can I adapt and adopt into my work, whether I'm a staff interpreter, whether I'm approaching this as a community advocate, whether my job is actually to run language access programs, or if I work in compliance or in quality within a hospital. How you adapt and adopt might be a little bit different, but the principles for improvement are the same. Now, it's important, when we've, invited the people with lived experience into the co-design process, that we help them develop new skills and that we cultivate them as long-term resources if they're willing. And if it's been a positive experience, they may very well be willing. Uh, we can invest in our community by providing additional training and feedback and support to the people with lived experience who are coming in to participate in the projects. We can introduce them to other organizations that are actively working in the community, and in this particular case, to build up language access infrastructure. We can invite them to recruit and mentor future participants, other PWLE. And we can invite them to present the improvement work in a public forum as well as internally within our organization. And all of this is skill building in the community. By doing this, we're growing our talent pool. And it is often possible to invite that person with lived experience to apply for employment within the organization at the end of the improvement project or at some future point. We can involve them in celebrating our improvement milestones in the community. And one of the suggestions from the IHI is here, and they said choose milestones, whether it's twice a year or quarterly or at the end of a project, and bring together stakeholders. Bring together the team members, the leaders, and the community. Showcase the diversity in your community resources, youth, seniors, emerging leaders. Invite community members with lived experience to co-design even the celebration of the improvement work, and to give their input on how to share this work more broadly. And when you do this, you're really, reaching through your bricks and mortar into the communities that you exist for, and the barrier between the institution and the community begins to dissolve because it's one, because the institution is reaching into the community and the community is reaching into the institution, and there is no stronger system than systems that are from the community and for the community and really involve the engagement of the broader community. So, a practical example, a real life example of this is Farah. Farah is a friend of mine. She's someone that I met through our work at Cambridge Health Alliance, which is that public safety net institution up in the Boston area. Cambridge Health Alliance is unique. It has a 43% LEP. So, in a typical year, the language access program is providing more than 500,000 interpreted encounters in about 100 different languages. There are thousands of patients. For example, 43,000 patients speak Portuguese, and 16,000 patients speak Spanish as a primary language. But there's so much language diversity. CHA says that we are from the community and for the community. Many employees are also community members and patients of the organization, and there's a real focused initiative now for more than 10 years, inviting PWLE to participate as improvement advisors, as members of family advisory councils, as patient partners, to bring them into the design of the system. So that's how I met Farah. She was a patient and a family member, a community member, and bilingual in English and Urdu. She was recruited as a person with lived experience back in 2014. And she's been in a patient partner role, which is a volunteer role, for about 9 years. She regularly participates in the co design of research projects, quality projects, and systems improvement, although she's not an employee of the organization, and has grown to present nationally on performance improvement initiatives. In 2020, Farah was a presenter for a webinar on creating your telehealth platform hand in hand with patients, the CHA story. And she talked about all of the work that CHA has done with people with lived experience like herself, and how patients were involved in building a better telehealth platform, and how this really has contributed to health equity, particularly during the pandemic. Um, Farah would occasionally reach out to me. We had served on some of the same improvement projects, and she would, write to me knowing that I was running the language access program, and she would say, I brought my father-in-law to the doctor the other day, and there was a delay in interpreter access, or this particular modality didn't work quite right, or I think we can do better for the Urdu-speaking population. And it was always wonderful to have those conversations. And she grew to become so passionate about language access and language justice that she enrolled in a interpreter training program offered through a local organization called Found in Translation. And the goal of Found in Translation is to help women, bilingual women, develop their language skills and become qualified healthcare interpreters. And they provide 140 plus hours of free training. And Farah came through that program. Today, she is a full-time Urdu interpreter with AMN. She attained her core CHI certification, and she continues to volunteer as a community member in performance improvement projects in the local healthcare organization at CHA. So I just think that's a really interesting example of the potential of people with lived experience and the value of inviting them in, and all that they can achieve and produce towards health equity in the communities in which they live. But the supports have to be there, and the openness has to be there to involve community members in this way. So, in thinking about these concepts, I'd love to know, and you can put this in the chat, what excites you most about this idea of co production in healthcare? Do you see where you might utilize some of these principles? I see that Elizabeth Gonzalez Soto wrote that people with lived experience are an underused resource, and she's happy to see that we're talking about this. And I think that these are ideas that we can bring back to our own communities, and not just talk about them, but kind of get them started. Build this. It's all part of building the language access infrastructure. Um, so think about how you can apply the principles of production in your work, and who you can partner with in the local health system with a community organization to begin to co-produce better language access infrastructure. I think we can all do this in different ways. And if some of you are in the same communities, you may be able to join forces and do this together. I've talked to some freelance interpreters, folks who work remotely, and they said, "Well, yeah, I mean, I don't service my local healthcare organization. I'm not employed by the local hospital, but you may be a patient." Or you may be the family member of a patient, and maybe that's where you get this started. Maybe that's where you focus your advocacy. Having moved from Massachusetts to Florida, the first thing I did when I got here was establish care. And I established care for my son at a pediatric specialty hospital. And in the intake process, they ask parents, "What is your occupation?" And I always say interpreter. And the nurse turned to me and said, "Oh, honey, I wish we had those." And so I asked questions as a community member, as the mother of a patient. What do you do when someone who speaks a language other than English, or someone who has deaf parents is here for care? And she described a very, very archaic and complex process. She said, "Oh, we call down to facilities. We ask them to bring us a telephone, and all of that takes time. And I just wish we had interpreters." And I think that asking these questions about what is the language access infrastructure as patients, as family members of patients, as community members, can help to start raising awareness about the need for hospitals to build better and to build in collaboration with us, with the communities who are ultimately end users of the service. Yeah. Susan Conway is saying the idea of co-production helping to improve a healthcare system is fantastic, and it also allows patients to have a voice. Absolutely. So it's okay to start small. You might not be able to overhaul the entire language access program. You certainly won't in one improvement project, but you can start with small improvements to pain points within your organization. Maybe the pain points are in wayfinding and navigation. Maybe you see that patients are lost at the entrance, that they're having trouble finding the departments. Maybe there's a need to involve them in a redesign of how we welcome them, ask them how they would want to be welcomed, a redesign of our signage. And we might be looking at the languages in which we have signage. We might be looking at the font size in which we have signage. We might be looking at the complexity or renaming certain services, or who knows what people with lived experience will tell us. We only know when we ask. So maybe that's where you start. We can involve our end users in conversations about the interpreting modalities. I think a lot of times hospitals will pour money into something and then present it to the community and say, "Look what we built for you." And it may not be at all what the community wanted or needed because they weren't asked. And so involving the end users, involving the community in conversations about, what modalities would you prefer? And does your preference change in different healthcare settings? What does the hospital have that you like? What don't we have that you would like us to implement? Um, and have you had better experiences in neighboring organizations? All of those are questions that we need to be asking. We need to be engaging our people with lived experience in the answers. This is also true about the interpreting modes. There are hospitals now in Georgia and California that have been for some time piloting simultaneous interpreting for spoken language in exam rooms and asking patients, would you like to hear this consecutively? Or would you like to wear a headset and hear the interpretation simultaneously? And there are patients and families who will say, "Oh, give me that headset because it helps me focus. And also, it saves time. I'd love to hear this simultaneously." And there are patients and families who will say, "We do have some English proficiency. We'd like to hear the clinician in English, and then we'd like to confirm our understanding by hearing the interpreter in a consecutive interpretation. But we won't know this until we ask, until we engage the people with lived experiences." And what those hospitals have done is essentially offered a menu of services now where patients have some say in how they want to receive the interpretation, in what modality, in what mode. And then, like Farah presented, we can involve our end users in the design of our telehealth systems. At Cambridge Health Alliance, we talk to patients about, what do they need to get to the telehealth appointment. And this was during the pandemic when we were implementing something new. And they said, "Well, all the screen options are in English. It would be really helpful if I could see those options in my language." And out of that came a design of a skin. They called it a skin that would allow patients to enter the virtual exam room in their language, English, Portuguese, Spanish, or Haitian Creole, to consent for treatment in that language. And then, once the provider entered the room, to have, of course, an interpreter conferenced in. But that came out of feedback from people with lived experience who said, "We're having trouble getting into the rooms. We need to be able to walk through the process and click on the options in our language." So, in thinking about co-production, for some of us, it is a new lens. And Doctors Batalden wrote, they said, like any paradigm, the construct of a co-produced healthcare service is imperfect because we're all imperfect. It contains its own challenges and hazards, but it doesn't mean it's not useful. And then you have this idea from literature that the real voyage of discovery consists not in seeking new landscapes, but in having new eyes. And so maybe, and the hope is that this lens of co-production can help us see healthcare services with new eyes. And ideally, not just with our own eyes, but with the eyes of people with lived experience. So I'm seeing some great comments in the chat. Izzy Olson is most excited about how it can increase fulfillment and reduce burnout among professionals. Absolutely. It can be really disheartening to invest time and energy and emotional attachment in something that isn't going to be useful to patients, that they don't necessarily want, that sting of rejection, we can do away with that when we involve the end users in the design. And that way we're all invested together and we're building something that they're telling us will be useful and will be valued. And then, it might not be useful forever. The thing about process improvement and quality improvement is that it's cyclical. And so you might build something wonderful that is wonderful for 6 months or a year, and then the needs of the community change, and it's necessary to come back to the drawing board. But by all means, come back with the right people, come back with the end users so that you can adapt, tweak, or scrap it and redesign something together that will be beneficial at that point in time. Yeah. Elizabeth Gonzalez Soto says that she feels that by co-producing with PWLE, we can also help bridge the gap of the current in-person shortage of qualified interpreters, similar to Farah's story. And I absolutely agree. Because we're applying these principles to building language justice infrastructure, we're going to attract people that already have an interest or a passion. And they may already have skills that we can maybe direct. And yes, we may be in some ways recruiting the next generation of interpreters by inviting bilingual individuals from our communities to participate in these improvement projects. Um, Farah fell in love with language access, wanted to be more involved on the front lines, and is currently a nationally certified healthcare interpreter doing tremendous good for Urdu speaking communities all over the country. So that's what I have for you. And I'm wondering what questions you might have for me. We do have a little bit of time. I know it's a lot to take in. These are excerpts of the IHI and the Robert Wood Johnson Foundation toolkits. Um, the toolkits themselves are quite extensive, and all of the links are here in the presentation. And I hope that you are able to take a closer look at them and bring them to your performance improvement teams if you do work within a hospital. Bring them to your language access leadership, to the people who are focused on health equity, and ask, have we involved people with lived experiences? Are there ways that we can begin to do this? And you might be surprised. Other groups within your institution working on other quality improvement projects may be using this model already. It's just perhaps no one applied it to the building of language access infrastructure. And you can pioneer that in your area of interest. Is there something you feel would be particularly challenging about this? Because it's not a small undertaking. And if so, you can put that in the chat too. I'd love to do this, but, and I think the buts are important because when we identify the potential barriers to this kind of work, then we again can work collaboratively to bring down those barriers. One of the barriers that I've heard is, we don't have the resources to go out and find the people. I don't think we have the resources to compensate the people. And that's a good conversation to have with the folks within your institution who hold the purse strings. A lot of these projects can get started even in environments with few resources, but organizational commitment is necessary. And I think if we can make that argument, the link between doing this work and the impact on health equity, then the people who are working towards health equity can get behind and provide the resources to get this started. Yeah. Izzy Olson, absolutely. Sometimes management will say that there are budgetary obstacles. Some organizations have been able to get grants that help them support the participation of people with lived experience. And those grants might cover maybe the compensation aspect. And sometimes that compensation is, not done in dollars per se, but in vouchers, in gift cards. Depending on what's relevant and what's needed in the community, and there are grants that can help you fund that there are grants that you might be able to tap into that could help provide the childcare for the people with lived experience who want to come to those meetings and participate in the projects. um, Elizabeth, I think you're right. One potential barrier might be that leadership is not knowledgeable about the connection between health equity and language justice and language access, and that's where you need to get up on your stool there, your soapbox, and make those connections clear. That with language access is fundamental to everything. Without language justice, there can be no social justice. Without language systems in place, we cannot achieve health equity. It's interesting that language access is not typically considered to be a social determinant of health, and this is somewhat controversial because it absolutely is, but it's not typically listed. It's listed as an other, but it's fundamental to everything. And so, if we can talk to our SDOH, our social determinants of health group, and say, let's look at language access as being one of these factors that can contribute to health equity or inequity, and let's build better systems to close those gaps. Susanna Jacobus, I hear you. We're in South Florida, and we'd love to help bring South Florida hospitals into the 21st century for language access. Yeah, there's a lot of practices that happen everywhere, not just in South Florida, that involve the use of untrained and unvetted interpreters, the use of friends and family, the use of bilinguals who have not been assessed for interpreting. How to create this awareness, I think we create it from within. And I think that's a great topic for a future webinar. Um, I'm happy to connect with all of you or any of you who want to continue the conversation. I'm happy to make introductions to hospitals that are involving patients with lived experience in their telehealth, in their front lines, in their wayfinding improvement projects, in conversations about modes and modalities. I'm all about making introductions. I'm happy to share the resources from these articles, and I'm happy to join you in conversations about how to get this going locally. I think in a place like Florida, we can look to systems that are building language access infrastructure. And there's wonderful examples in St. Augustine, in Orlando, in Tampa, in Miami, of hospitals that have made this an institutional priority, even in an environment where it's not necessarily a government priority. And Sean Norris is an example of that, doing that over in the St. Augustine area. And I think that when you live in the community in which you work, you can become a trusted voice, and really have an impact in terms of grassroots advocacy. Well, thank you all for spending this time with us.
Thank you so much, Vanessa. That was wonderful. So yeah, I encourage everyone to check her out on LinkedIn. She's a great follow. And she's also been a big help to me when I was working on getting my stuff started for my own healthcare system. So she's very responsive. And there are several others in our industry who do a great job. So thank you again, Vanessa, for that enlightening topic. All right. I want to thank you guys for everything you've contributed to our discussion for today. We hope that you've enjoyed this. We're hoping to bring more webinars like this to you guys. So feel free to check out our website, hellointerpreters.com. Our goal is to provide a lot of resources, articles, webinars, a community where you guys can connect with each other to support one another. So please check that out. I'd also like to thank our sponsors, Sorensen and Cross Cultural Communications, for helping make these webinars available to our community. I think it's really important that we give back not just to the communities we serve, but also to us as professionals, as interpreters, as translators. I think it's really important that we are here for one another. It can get kind of lonesome in our business because we typically are working solo. Maybe we do some teamwork if we're doing conferences and things like that, but typically you're solo. Just want you to know that there's a community here for you at Hello Interpreters. I want to thank the interpreters as well who are here with us, Ashley and Sarah. They did a great job today. And again, I want to thank Vanessa for contributing her time here with us. And I also want to thank all of you for taking the time here. We will be sending out an email to those who have attended to ensure that you get your CEUs that you have requested. Please fill out that survey. And then again, please check us out, hellointerpreters.com. And thank you guys. Take care.